Chapter 16, Depressive Disorder, Part 1. Depression is the oldest and one of the most frequent diagnosed psychiatric disorders. An occasional feeling of sadness or downheartedness is common among healthy people and considered to be a normal response to everyday life disappointments. However, it becomes pathological or a mental illness when a person is experiencing impaired function as a result of this depression, as well as they are having ineffective adaptation techniques. So, mood is persuasive and sustained emotion that may have a major influence on the person's perception of the world. So, an example of this is mood includes joy, depression, elation, anger, as well as anxiety. So these are all types of different types of moods. So anxiety, so someone may say I'm anxious, or I'm elated. Effect describes the external observable emotional response associated with the experience. So depression is an alteration in mood that is expressed by feelings of sadness, despair, and pessimism. There is a loss of interest in usual activities, and somatic symptoms may be evident. Changes in appetite, sleep pattern, and cognitive changes as well. So someone may start to become forgetful. That is a cognitive change. Historical perspective. Many ancient cultures believe in the supernatural or divine origin of mood disorders. But non-divine point of view regarding depression was held by a Greek medical community. So they believed they strongly rejected the idea of divine origin and considered the brain to be the seat for all emotional states. Epidemiology. Major depressive disorder, MDD, is one of the leading causes of disability in the US. The lifetime prevalence of depression is about 17%, which makes it the most prevalent psychiatric disorder. 6.7% of people aged 18 or older had at least one major depressive episode in the previous year. So, gender prevalence is that women are more likely to be affected by depression than men, with a 2-to-1 ratio. And for age, people age 45 or younger are more likely to be affected by depression than older adults. So, social class. There is an inverse relationship between social class and the report of depressive symptoms. Racial and cultural. No consistent relationship between race or affective disorder has been reported. Problems have been encountered in reviewing racial comparison. Marital status. Single and divorced people are more likely to experience depression than are married persons or those in a close interpersonal relationship. So, studies have been done on the changing of seasons, and they have found that affective disorder is more prevalent in winter and fall months. Types of depressive disorder. So, the first one we're going to speak about is major depressive disorder. And major depressive disorder is characterized by depressed mood, loss of interest and pleasure in usual activities. Evidence will show impaired social and occupational functioning. There's our common theme, right? As well, that lasts, at least 2 weeks. No history of manic behavior and symptoms that cannot be attributed to the use of substances and general medical conditions. This diagnosis is also identified by severe severity of symptoms, mild, moderate, or severe, and whether there is evidence of psychiatric, catatonic, or melancholic features. Persistent depressive disorder or dysthymia. So, this disorder is characterized by milder MDD, which is major depressive disorder. There's no evidence of psychotic symptoms. The essential feature is chronically depressed mood or possibility of irritable mood in children or adolescents for most of the day. More days than not, at least for 2 years, and 1 year for children or adolescents. The diagnosis is identified as early onset, occurring before the age of 21, and the late onset occurring after the age of 21. Premenstrual dysphoric disorder. The essential features of premenstrual dysphoric disorder are marked by depressed mood, excessive anxiety, mood swings, decreased interest in activities during the week prior to menses, improving slightly after the onset of menstruation, and becoming minimal or absent in the weeks post menses. Substance abuse or medication induced depressive disorder is considered to be a direct result of the physiological effects of a substance, such as alcohol abuse, methamphetamines, cocaine, hallucinogens, opioids, sedatives, hypnotics, or anxiety medication. Then we have depressive disorder associated with other medical conditions. So this disorder is characterized by major depressive episodes that are a direct consequence of another condition. So depression causes clinically significant distress or impairment in social, occupational, or important areas of function. So someone's depressed because of this medical condition. So maybe they lost a limb, right? Or had a CVA and now they're dependent upon someone for care. Predisposing factors to depression. So on this slide, we list two biological theories. So I do want to mention that depression is not clearly defined what is the cause of depression at this moment. There is no evidence that supports any one particular cause. Genetic link may be suggested in some of the studies. However, the gene transmission has not been proven. And then we have our biochemical influence. So depressive illness may be related to a deficiency of neurotransmitters such as norepinephrine, serotonin, and dopamine at functional receptor sites in the brain. More recently, the hypothesis has been expanded into another neurotransmitter such as acetylcholine because cholinergic agents do have profound effects on your mood and electroencephalograms as well. That's just the brain activity, electric activity in your brain, sleep, and neuroendocrine function. It has been suggested that the problem with depression and mania may be an imbalance of both biological anamines and acetylcholine. Neuroendocrine disturbances. So it's believed that possibly the failure of the hypothalamic pituitary adrenal cortex axis and possible diminished release of thyroid stimulating hormone may cause depression. So studies have shown that approximately 25% of depressed people appear to have a decrease in their thyroid stimulating hormone. Predisposing factors to depression that are physiological. So medication side effects, and there's many medications that affect your central nervous system, which may cause a depressed mood. Then we have neurological disorders such as brain tumors, Parkinson's, Huntington's disease, Alzheimer's, a CVA that or stroke that affects your temporal lobe. These could, and multiple sclerosis as well, can cause symptoms of depression. Excess levels of sodium bicarbonate or calcium, as well as a deficit in magnesium or sodium, and potassium has been implicated as well as one of the electrolytes that may cause depression. Hormonal disorders. So, an imbalance of hormones such as estrogen or progesterone may cause depression, as we read in our pre-dysphoric disorder, the different cycles, times of the cycles, how the person's moods changed. Nutritional deficits, so deficit in proteins, carbohydrates, B1, which is thiamine, B2, riboflavin, B6, pyridoxine, B9, folate, and B12, as well as iron, zinc, calcium, iodine, lithium, potassium, and omega 3s. All of these can cause a depressed mood if they are in deficiency. Other conditions that may be associated with a secondary depression includes collagen disorders such as systematic lupus, SLE, or polyarthritic nodosa, cardiovascular disease, cardiomyopathy, CHF, myocardial infarction, infection, and this infection can be um, um, of the brain as well as the liver. It could be like pneumonia, syphilis. All of these can affect a person's mood, and that's due to the inflammation that's being caused by that particular disease. So, predisposing factors to depression, psychosocial theories. So, psychoanalytic theory, which is the loss of internalized or becoming directed against the ego. So, we briefly learned about the id, ego, and superego a few classes ago when we were learning about anxiety. And the learning theory, um, psychosocial theory, is learned helplessness. The individual who experiences numerous failures learn to give up trying. Psycho theories continued. So we have the object loss theory, which suggests that depressive illness occurs as a result of having been abandoned by or otherwise separated from a significant other during their first 6 months of life. The absence of attachment, which may be either physical or emotional, leads to feelings of helplessness and despair that continues into their lifelong pattern of depression and response to loss. Our cognitive theory, which is another psychosocial theory, views the primary disturbances in depression as cognitive rather than affective. Three cognitive distortions that serve as a bias for depression include negative expectations of the environment, negative expectations of the self, negative expectations of the future. Developmental implications include childhood depression. So symptoms up from birth up to 3 is feeding problems, tantrums, lack of playfulness and emotional expressiveness. Age 3 to 5 is the child is accident prone. They have phobias, excessive self reproach. Age 6 to 8, they may have vague physical complaints, and aggressive behavior. They may cling to parents and avoid new people and challenges. They may lag behind their classmates in social skills or academic competence. At ages 9 to 12, common symptoms are morbid thoughts and excessive worrying. They may they may reason that they are depressed because they have disappointed their parents in some way. There may be a lack of interest in playing with friends. The incidence of depression among school-aged children is estimated to be around 2 to 3%. Okay, so childhood depression continued. Other symptoms of childhood depression may include hyperactivity, delinquency, school problems, psychosomatic complaints, sleeping and eating disturbances, social isolation, delusional thinking, and suicidal thoughts or actions. The focus of therapy with depressed children is to alleviate the child's symptoms and strengthen the child's coping and adaptation skills with the hope of possibly preventing future psychological problems. So, parental and family therapy are common to help younger depressed children recover. Depression may be even harder to recognize in an adolescent than a younger child. Common symptoms of depression in adolescents are inappropriately expressed anger, aggressiveness, running away, delinquency, social withdrawal, sexual acting out, substance abuse, restlessness and apathy, loss of self esteem, sleeping and eating disturbances, and psychosomatic complaints are common. Developmental implications for adolescents continued. So, a visual manifestation of behavioral changes that lasts for several weeks is the best clue for a mood disorder. So, example may include the normal, outgoing, extrovert adolescent who has now become withdrawn and isolates themselves. The good student who previously received high marks is now failing and skipping classes, and usually self confident teenager who is now inappropriately irritable and defensive with others. Developmental implications continue for adolescents. So, for treatment, psychosocial interventions that are supportive, the patient may need antidepressant medications. All antidepressant medications carry a Food Drug Administration black warning for increased risk for suicide in children and adolescents. Development implications. Ch16. So bereavement overload. High percentage of suicides among elderly. Symptoms of depression often confused with symptoms of neurocognitive disorder. Treatment includes antidepressant medications, may use electroconvulsive therapy or ECT, as well as psychotherapies. So, postpartum depression may last a few weeks to several months and is associated with hormonal changes. The treatment could be antidepressant medication and psychosocial therapy. So, women who give birth, approximately 50 to 85% experience the blues following delivery. The incidence of moderate depression is 10 to 20%, and severe to psychotic depression occurs rarely in about 1 to 2 out of 1,000 postpartum women. Postpartum depression continued. So, treatment of postpartum depression may vary depending upon the severity of the illness. Symptoms include fatigue, irritability, loss of appetite, sleep disturbances, loss of libido, concern with inability to care for infant. And so, supportive psychotherapy, such as group therapy or possibly family therapy, may be warranted along with antidepressant medications.